Sensory Integration by Jennifer Lidgard, Joshua Oliver, and Kirsten Voss. Topics we will discuss include the founder of sensory integration, the historical timeline, the definition of sensory integration, associated terms, the theoretical base, and common diagnosis in populations. Sensory integration was first developed by A. Jean Ayres in 1972. She was an occupational therapist who did postdoctoral research in education and neuroscience. She observed children with learning problems to develop this theory and to dig deeper into the existing perceptual motor theories. Ayres worked on the theory for a number of years. Throughout those years, the key ideas remained the same, but a few changed. In the 1960s, the focus was on children and adults with autism and developmental and neurological delays. In the 1970s, the shift was to children with learning disabilities. In addition, she created standardized assessments and clinical observations, innovative therapeutic equipment, and validated her findings through many research studies. So what is sensory integration? It is the ability to take in information through our senses and effectively utilize the information to respond to demands of the environment. This theory believes that adequate processing and integration of sensory information is an important foundation for adaptive behavior. Integrations between sensory systems provide integrated information that leads to increasingly complex behaviors or end products. Senses involved in this theory include auditory, which is your hearing, vestibular, which is gravity and movement, proprioception, which is your muscles and joints, tactile, which is your touch, and vision. Using proprioception, an occupational therapist may have a child grip a pencil, use adaptive scissors, pick up heavy objects such as weights or a weighted item, or do a body wheelbarrow walk. This allows the child to become aware of his or her body's position and movement. This also interacts with the child's tactile senses, which focus on body awareness and coordination of the two sides of the body. Both of the child's proprioceptive and tactile senses are working together on the end product of hand-eye coordination, visual perceptual skills, and the participation in purposeful activities. Occupational therapists work with a variety of populations. They work with infants and toddlers who are at risk for developmental problems or who have disabilities. The occupational therapy interventions allow the infant to become successful in their occupational performance, which is essential for their development. They also work with children with sensory integration problems who need help focusing on life skills, participation, and behaviors at home and in the community. Intervention can assist them to be as independent as possible in their daily life, at home, and school. Adolescents and young adults may have sensory integration problems associated with fear of movement, sensitivity to touch, poor motor planning, or decreased awareness of body position in space. Occupational therapists can help find ways for adolescents and young adults to become successful in these areas. In addition, adults with sensory integration disorders may have difficulties with interpersonal skills, vocational skills, and leisure activities. They may have never been diagnosed with a sensory integration problem and need to work on ways to develop coping skills and adaptive performance mechanisms.
Next, let's discuss function and dysfunction. Function in sensory integration is defined as the absence of sensory integrate dysfunction or the inability to process sensory stimuli from the environment and produce an adaptive response. Disability is defined as the inability for a person to process sensory input from the environment and to produce adaptive responses.
In order to understand sensory integration theory properly, you must be aware of the theoretical base. The theoretical base includes 7 postulates. Sensory integration provides an important foundation for learning and behavior. The second is that sensory integration is a developmental process. Because of this, the therapist should follow the developmental scale starting at the current level of performance and progressing with the client. It is important to understand the typical development and patterns that go along with client's age. The third is successful integration and organization of sensory information starts in and is further developed by the adaptive responses. An adaptive response is an appropriate action in which the individual responds successfully to some environmental demand. This is to say that the organism or the individual and the environment interact and are affected by each other. The fourth is the just right challenge. Provides the conditions for sensory integration to occur. For this learning to occur, the child meets and successfully accomplishes a challenge. The activity that the therapist provides needs to be gradable, meaning that it needs to start where the client is, as well as offer challenge for future growth. The therapist must consider the context, child's needs, developmental level, interests, motivation, and sensory motor deficits. Fifth is that children have an innate drive to seek meaningful experiences from their environment, though response to stimuli dictates this relationship, which we will talk about later. The sixth is that neuroplasticity causes enriched experiences to cause change in the nervous system. This means that the environment and the person's response to it shapes the brain on a cellular level. The seventh is that sensory integration foundation, physical and social engagement, and participation in daily living activities and routines. Children with sensory integration impairments often fall behind peers because of the interactions that they have with the environment and peers. These things can be challenging, and this low social interaction often results in immature behavior. So putting it all together, providing an enriching environment full of occupational sensory opportunities, which are processed in the brainstem, helps to stimulate the client's motivation via the limbic system. With the just right challenge, sensory and motor tasks can be guided to produce neurological and behavioral change in the client. As the client completes higher levels of adaptive responses, this builds their self-esteem and self-efficacy, making them more willing to engage in future challenges in everyday life.
Associated terms with sensory integration include sensory modulation, sensory discrimination, praxis, postural ocular control, and bilateral integration and sequencing, all of which we will discuss in the next few slides.
Sensory modulation is the ability to use these senses and appropriately adapt to various stimuli, depending on intensity and duration. In a functional individual, they will also have the ability to maintain these levels of arousal and attention to meet the demands of the task. If they are unable to adapt appropriately to one or more various stimuli, depending on intensity and duration, they may also have difficulty maintaining the level of arousal and attention to meet the task demands. Some reactions and subtypes of sensory modulation dysfunction include low response to stimuli. In this case, the individual will often ignore or seem very passive to the stimuli when presented. This individual will have less intense sensation and lower response. It is often hard to engage these individuals due to a lack of inner drive to explore because they do not have as intense sensation. On the other hand, high response to stimuli experience a stronger and more intense sensation and often react quicker. These individuals most of the time withdraw and or avoid situations that cause these strong and intense sensation. They may engage in aggression with a desired consequence of avoidance of that situation. The third sensory modulation dysfunction is sensory craving or sensory seeking. These individuals cannot satiate their desire for sensory input. Because of this, they may move, touch, watch, or seek loud noises or unusual olfactory and gustatory sensations. Keeping these individuals focused on a single task will be difficult. An individual may also have a sensory discrimination. In order to respond properly to a sensory stimuli, a person must also be able to discriminate between stimuli. This ability to distinguish between various stimuli is called sensory discrimination. It allows a client to respond appropriately to sensory stimuli by answering 3 vital questions. Where is it? What is it? And when did it occur? This adds spatial and temporal qualities to the sensory stimuli. A person with a dysfunction in this area may have the inability to distinguish between various stimuli. The client will have trouble responding appropriately to sensory stimuli and or be unable to answer questions about where a stimulus is coming from, what it is, or when it occurred. This causes this individual to develop incorrect perceptions of events as well as how they interacted with the environment. In terms of sensory discrimination, somatosensory is the ability to discriminate touch and proprioceptive stimuli. This includes information about spatial and temporal qualities of the environment gathered from skin receptors. The proprioceptive discrimination provides understanding of the body's position and load and tension on joints, and it is the one of the founding principles of motor planning. Another discrimination type is vestibular. This is the position of head relative to gravity. As you can imagine, this works with the somatosensory discrimination to provide postural control, balance, and equilibrium, which are used in everyday tasks. The visual discrimination allows the individual to position themselves in the environment, as well as location of objects, figures in their environment. This includes the movement of objects through a visual field. For example, if somebody is on a swing and they are going around in circles, the visual sense will be rotation. It combines the somatosensory and fine motor abilities. Auditory discrimination is the differentiation of sounds, often in terms of speech. Accurate sensory perceptions are needed to create an accurate plan for future action. If the individual has a sensory dysfunction, this may be displayed as a dyspraxia. But first, let's talk about praxis, which is the ability to conceive of, organize, and carry out a sequence of unfamiliar actions. The sub-processes include ideation, motor planning, and sequencing execution. All of these together lead to feedback. Dyspraxia, which is the inability to conceive of, organize, or carry out a sequence of unfamiliar actions. This way, a person is unable to think of a task, put those tasks and the necessary actions in the correct order in a new setting. This dyspraxia can affect any of the sensory discrimination types. Some common dyspraxias are somatodyspraxia, primarily tactile and proprioceptive deficits. This is to say that if they were to touch a soft object and they had an aversion to soft things, that there would be a high response causing an inappropriate reaction, and that causing a feedback that would also create an inappropriate memory of that reaction. Because of this, they have poor motor planning, difficulty learning and organizing motor actions, and generalizing to new actions. Another dyspraxia is bilateral integration and sequencing deficits. This is characterized by poor vestibular and proprioceptive discrimination. This causes the task to be extremely inefficient and slow, but has no grounds in cognitive ability. The results of dyspraxia may be that the individual has to work harder than other individuals in the class, which makes it harder to learn new skills, especially in new situations, which can cause an inability to do motor tasks safely, and often can be hard to follow directions, especially if they have an auditory deficit in which they cannot hear or do not attain verbal language. Some of the assessments include the sensory processing measure. This is a standardized scope that allows us to view the highest level integrative functions. This measure also looks at the sensory system through measuring visual, auditory, tactile, proprioceptive, and vestibular function. The next assessment is the Sensory Profile 2. The Sensory Profile 2 is typically administered through paper or pencil, but can also be scored and taken electronically. It can be completed by the caregiver, teacher, or the OT, and it helps to identify the effect of sensory processing on functional participation. The next assessment is the BOT 2. This assessment is appropriate for school-aged children as well as young adults, and is typically administered through paper and pencil, and is completed by a trained therapist. This assessment is a performance measure that looks at fine and gross motor ability. The next assessment is the PDMS-2. This assessment looks at children from birth through 5 years, and is typically administered through paper and pencil and completed by a trained therapist. This type of assessment is also a performance measure, looking at reflexes, stationary, locomotion, object manipulation, grasp, and visual motor integration. It is commonly used in the diagnosis and treatment of clients with CP. The next assessment is the MFUN. This assessment is used with school-aged children, and it also administered paper and pencil, completed by a trained therapist. This is a performance measure that looks at fine, visual, and gross motor skills. The child's ability in these areas affects their occupational engagement. The next assessment is the SIPT. Assessment is used in school-aged children and also administered paper and pen trained therapist. This performance measure looks at the visual, tactile, and kinesthetic perception, as well as motor performance.
Critiques of this model include both pros and cons. Pros include the ability to adapt to a client's needs, multiple disciplinary and evidence-supported. Cons include controversial terms and amounts of evidence-based practice. How can OT help? OT can help by collaborating with families, physicians, nurses, speech-language pathologists, physical therapists, psychologists, teachers, employers, and other professionals to determine the need for specialized evaluation and intervention. We can also help by identifying and modifying sensory and environmental barriers that limit performance and participation in everyday activities, as well as individual strengths and supports. We can teach and model activities to support sensory, motor, and behavioral needs, and we can also identify and provide adaptive sensory and motor strategies and interventions using a variety of sensory approaches to facilitate full participation in daily routines and social interactions. And finally, we can help raise an individual's self-awareness of the impact of sensory and motor factors on everyday activities and real-life situations. Thank you for watching.